Welcome to Noon Wednesday. I'm Marissa Wojcik, multimedia journalist with Here and Now on PBS Wisconsin. Today is July 7. Scientists and public health officials are using genome sequencing to plan for future pandemics and to detect variants of the SARS-CoV-2 virus, such as the more contagious Delta variant. Joining me today are two UW-Madison virology professors and researchers, Tom Friedrich and Dave O'Connor. Thank you both very much for being here.
Thank you for
Good to be with you.
David, I want to start with you. The variant of the SARS-CoV-2 known as Delta is now the most dominant strain in the United States, as recently reported by the Centers for Disease Control. What do we know about the Delta variant?
Well, we know that this Delta variant is the dominant variant because it is more contagious. That means it spreads more easily. And so you can imagine that if with a previous variant, you might have needed to be in a room with someone who is infected for 5 minutes to become infected. Now maybe you only have to be in a room with them for 2.5 minutes to become infected. So we know that it's more contagious, and we know that people who are vaccinated are going to be protected from severe disease. So the really good news is that if you've gotten your vaccine, you're not going to get sick with the Delta virus. However, you might still get infected and be an asymptomatic carrier, which means that you could potentially infect those around you who are unvaccinated. And so these two features, its high contagiousness and the fact that it can be spread by people who are vaccinated and asymptomatic, are what has allowed it to get a foothold in the United States and in Wisconsin so quickly.
And Tom, what do we know about who specifically is mostly contracting the Delta variant and how sick they're getting?
So this is a good question. And as Dave indicated, most of the people who are getting sick with the Delta variant and indeed with COVID generally in the United States are people who are not vaccinated. But it's important to remember that there are other people in the population who are vulnerable, either because they're not vaccinated or because they may have weakened immune systems because they have cancer, or they are being treated with anti-rejection drugs because they're transplant recipients, and those people are also at risk. And so it's important for all of us to do our parts to reduce transmission of this variant as best we can.
And so, David, if you are vaccinated, you said you can still contract and transmit the Delta variant. So does that mean we should still be wearing masks when we're out in public? How seriously should we take it?
Well, as long as the case numbers remain very, very low, the likelihood that you're going to encounter someone who's infected is going to be very low. And so I think what we have, at least here in Dane County, where we have a very high vaccination rate and a very low number of cases, is okay for right now. But we do need to be open to the possibility that if case numbers rebound and they go up again, that we might need to return to more aggressive masking and other risk mitigation policies in the coming weeks and months. And as the weather gets colder and we spend more time inside, we're going to need to see what effect that has on the spread of the virus. And we're going to need to potentially change the public health measures accordingly. So I think it's maybe a little bit too optimistic to say that just because we have a high vaccine rate, that means the pandemic is over. I think what we should do is enjoy this moment that we're in right now when case numbers are low. People who are not yet vaccinated should take this moment to get vaccinated so that in 6 weeks or so, they'll be fully vaccinated and have the best possible protection from the Delta variant and other types of the virus that might come in the future. And we just need to be very watchful. So I liken it to being on a beach in Florida before a hurricane. Right now, the sun is out, the waves are great, enjoy your time on the sand, but there might be a storm well off to sea that we need to be worried about in the future.
Tom, does the type of COVID-19 vaccine that you receive impact the efficacy against the Delta variant or variants that we have not yet seen emerge?
So the short answer to that question is no. As far as we can tell, the type of vaccine does not really affect the ability of a vaccinated person to be protected from Delta or other variants that we already know about. There are two important asterisks to that, however. The first one is that there's some data coming out of the UK suggesting that for the 2-dose vaccines, the Pfizer and Moderna vaccines, and probably also AstraZeneca, but I'm not so sure about that one, that you have to be fully vaccinated in order to have the protective effect against severe disease from the Delta variant. So people who only have 1 dose are not well protected against Delta. And similarly, we do not know how this virus will evolve in the future. There are already indications that the Delta variant may have some new mutations like that get incorporated into this Delta variant. There are other mutations we know about that may affect the ability of our immune response to recognize that variant that the kind of standard Delta variant does not have, and it may acquire. And so that may make that sort of new variant even less recognizable to our immune systems, and we have to be ready for the future evolution of that virus. So it's hard to predict how the vaccines will work against future variants that haven't come around yet. I would add one important thing to Dave's answer just now, which is also that we have to remember that school-age children under the age of 12 cannot be vaccinated yet. And so when he talks about how we may need to prepare for a future where there's more transmission, when our kids go back to school and those kids aren't vaccinated and won't be able to be vaccinated yet, we may see a change in the patterns of COVID transmission, and that's something that we're going to have to pay close attention to.
And Dave, as you were talking, in Wisconsin, the Department of Health Services began reporting last month cases of the Delta variant, and the most recent data that we have is now about a week old, and at that point it said 71 cases statewide. But with testing going down and more people getting vaccinated, is it difficult to decipher how accurate that 71 case count might be if it's highly transmissible and people aren't finding a way to have that detected?
Sure. So that's a great question. The good news is that at this time last year, we had more cases in Wisconsin and much less viral sequencing. So viral sequencing is the process where we read out the 30,000 letters that comprise the virus's genetic sequence. And we can use that to determine whether a virus, it looks like a 2020 virus, whether it looks like a Madison, a Milwaukee, a Green Bay virus, whether it looks like a Delta virus or an Alpha virus. We can get that by sequencing the virus. And right now, we and our partners at the Wisconsin State Lab of Hygiene and the Marshfield Clinic and several others throughout the state are really trying very hard to try to sequence every virus that we can get sequenced from statewide. And that's a huge change from this time last year, where in Dane County, we had about 5 to 10% of the test positive cases being sequenced, but statewide it was much, much less, 1 or 2%. So we have a really good visibility into these Delta viruses among people who are being tested. But as you point out, our ability to pick up these cases is only as good as our ability to test. And since we have this indication that people who are vaccinated might become infected but not develop a lot of symptoms, there's a very real possibility that we're going to be missing a lot of cases, and that the lag time between when someone provides a sample and when a sequence gets generated and when those statistics become available through the state means that we're already going to be a couple of weeks behind in the reporting. So I wouldn't put too much faith in the specific number of 70. What I would say is that I think a week before that it was 35 and now it's 70. we can reasonably anticipate that it's going to continue going up, and this virus is going to displace the viruses that were circulating previously. And so that risk of increased contagiousness for people who are unvaccinated is going to continue to grow and amplify as we move through the summer.
Now, Tom, the Rockefeller Foundation is working to create an international pandemic prevention institute, and the UW-Madison is recently a partner in that effort. So can you tell us about these plans? How do we prevent a future pandemic going forward?
Sure. I think that one of the main things that we've learned in the last 10 or 15 years is that diseases like COVID will continue to emerge and threaten global health. They may threaten health locally before they become global pandemics. And what we'd like to do is to be able to detect the emergence of a new disease like COVID locally where it's happening, and then hopefully stamp it out before it becomes a globally disruptive pandemic like the one we're living through. In recent years, we've had the outbreak of Zika virus in the Americas. We've had the 2009 influenza pandemic. We've had a, large-scale outbreak of Ebola in West Africa and so on. And what has tended to happen in the past is that there is an international response to these outbreaks that kind of starts to ramp up as the outbreak becomes severe. Maybe funds and supplies become available as the outbreak is waning, and then it sort of goes away, and then we sort of take our eye off the ball. So there's a boom and bust cycle in the funding and thinking about how to respond to pandemic and potentially pandemic diseases. So what Rockefeller and other partners are trying to do is lay the foundations for a more sustainable approach to detecting and then hopefully stopping emerging diseases before they become pandemics. So instead of just forgetting about COVID after it seems to go away in another year or two, hopefully that'll happen. We want to have a system of laboratories and close relationships between those laboratories and public health practitioners on the ground who can take the kind of information about viral gene sequencing that labs like Dave's and mine can generate, and then use that information to help inform a public health response on the ground. So what that might look like is, reading these sequences and learning, okay, there's a new virus in this location. We're seeing Delta emerging in our backyard. So maybe that means we have to look carefully at who is getting Delta and what are the drivers of those outbreaks. And so that sequencing can then inform a better tailored and targeted public health response. So what we're trying to do with this sort of international institute is define best practices so that labs and public health practitioners and clinicians can all work together better to get a better handle on COVID, and then use that as a model to respond to whatever comes next, because unfortunately there will probably be something.
And that sounds like a heavy lift. Dave, as you already described, you described trying to sequence every test of the virus. Taking a baby step back, can you just give us a quick sense of what genome sequencing is and why does this kind of surveillance matter?
Sure. So genomic surveillance is really just reading the letters in the virus's book to basically determine what it looks like. And so you may have heard of people getting their genome sequenced if they have a rare disease, or if they have a family history of disease, or if they have cancer. There you read the body's genome, which is about 3 billion letters long. Viruses are a lot simpler, so the COVID virus's genome is only 30,000 letters long. So we just read those 30,000 letters with fancy instruments in the lab. The trick is, of course, to make that information actionable. So Tom and I both spent much of our careers working on HIV, and one of the things that we have learned from working on that is that all the technology in the world doesn't make a whit of difference if it can't be brought to the communities that need it. And if the information about how to use that knowledge isn't there. And so really working to bring the technology to the people who will benefit from it is a big part of what this institute is all about, and is a big gap that exists between labs that can generate this really sophisticated and fancy data and the people on the ground who would be able to use it most effectively, to tailor public health messages, to identify people who are at greatest risk, to identify if there's a community that does have a fast spreading variant that we need to be worried about, and really communicating that effectively. So there's huge amounts of places where we can work with public health, and public health can work with us, and we can join hands more tightly to try to use this fancy technology to help the greatest number of people possible.
So, Tom, why didn't this bridge between public health and people researching these viruses, why wasn't that bridge there before? And once we build that bridge, will the recommendations for social distancing, wearing masks, those have become political? Will it be difficult to get the messages out to people to follow the guidance?
Well, those are both good questions. I think there are a couple of reasons why these bridges have not existed so much before. And the first is simply that there's been a revolution in gene sequencing technology that's occurred over the last 10 or 15 years that has made it increasingly easy and cheap to sequence viral genomes. And so the scale of genomic sequencing for COVID viruses that's occurring worldwide, I mean, that there's hundreds of thousands of individual viral sequences that are now in global databases that provide these kind of genetic fingerprints that let us track very closely how certain viruses are moving through space and time, and understanding these drivers that we've been talking about of transmission. So that has only become possible through this revolution that's made the approach faster, cheaper, and easier. So that means more labs in more places can do it. And that's just something that even 5 years ago or 10 years ago, about when there was the 2009 influenza pandemic, that just wasn't possible at the same scale. And so because it hasn't been that possible before, people haven't really thought a lot about how to take this very sophisticated information, very detailed information, and make it digestible, accessible, and actionable in the public health setting. So we have some databases on the public health side that allow us to track, where there may be cases of a certain infection, but those databases were not built with viral sequence information in mind. And so it's difficult to get this information in there. And also in our country, public health is highly decentralized. And so it's really overseen by state, county, and local health boards that all use different information systems and have different levels of staffing and budgets that are just not really equipped to handle this kind of information. So part of this push that we've been talking about is just to think about how to modernize the data tracking that we will need to be able to link this information that is now easier to generate back to public health. So that's why these bridges have not been stronger in the past. And I can't remember the second half of your question. I'm sorry.
Will it be difficult to get people to follow guidance once we have these new bridges built, because it's become kind of a political stamp?
Well, I think that there are going to be challenges for sure. And certainly one thing that I did not fully anticipate coming into this pandemic is the extent to which just sort of basic public health recommendations like wearing a mask would become kind of suffused with politics. So it's difficult to extract politics from anything that we talk about these days, unfortunately. And so there may be more barriers than we foresaw. However, I think that by kind of decentralizing access to this information and sort of more democratizing, if you will, the generation of this kind of sequence information because it's getting easier to do, then local health departments can tailor messaging to their local communities, hopefully in ways that local communities will find more engaging and easier to understand and follow than if it seems to be coming down from above from someplace far away.
The pandemic certainly has accelerated a lot of things in their pace. And I want to touch on, David, you're analyzing samples of environmental air and how much of a virus could exist in the air. And that's wrapped up in this work with the Institute. Can you describe that for us?
Sure. So this actually builds on Tom's answer, which is that as we go through the pandemic, we realize that there are going to be people who are not interested in being tested. They don't want to deal with COVID. And yet that doesn't mean that the virus isn't around. So we have to come up with innovative ways that we can look for the virus and understand it, even in places where there might be some resistance to getting tested, or there might be some mistrust. And so one way to do that is to surveil the environment where people live. And so one way to do that is by looking at wastewater. So there's been a lot of work done around the country in the last year or so, looking at how much virus is present in the wastewater. Here in Wisconsin, our State Lab of Hygiene collects and analyzes wastewater from around the state every week to determine how much viral genetic material is found in it. And that can be a predictor of how many cases we might expect at some point in the future. The other thing we can do, and we're starting to do, is do the same thing, but with air. So imagine that you would have samplers in airports or bus stations or malls, places where people come together, where you could basically collect and capture the air, count how much virus or genetic material is in the air, and sequence that virus to determine which viral variants are present. And in fact, part of that Rockefeller Institute that you referred to earlier is going to fund putting air samplers in here in Madison, in Milwaukee, in Marshfield, and then with partners in Minnesota. And so my office has actually been commandeered as an air sampler storage facility for the moment. And one of the air samplers is here behind my left shoulder. So they're pretty simple devices. They look like Sharper Image air filters. You just plug them in, you run them quietly in the background, and then you collect a filter after 10 or 12 hours, and you see what's been trapped on that filter, and then you can analyze it. So this is a perfect example of how the sort of innovation that can be tested out in universities where we have the luxury of time and the freedom to explore can first be prototyped in places like UW-Madison. And then if it works, once the bugs have been ironed out, you can bring it to places where it would be really useful. And you could give this to local public health departments or the schools to use it as an additional tool to help provide an extra layer of protection and information.
Now, this last question is for both of you. David, I'll start with you. What has been a big lesson learned, either through your research or even your own personal experience as you've been navigating this pandemic?
Well, I came of age as a student in the early 90s, in the peak of the HIV epidemic. And the HIV epidemic has become the defining professional challenge of my career. I've been working with Tom and with others on this for more than 25 years. And one of the things that I realize in talking to other people, other young people, my son is 12, and so I interact with our undergrad students and kids my son's age, is that this pandemic is going to put that same sort of dramatic, life-changing imprinter on them as the HIV epidemic did for me when I was about that age. And what that does is it creates an opportunity that I don't think we've ever had before, where some of the greatest young minds today, the people with the greatest amount of ambition and energy and talent, are going to be thinking about health, science, medicine in ways that they never did before. And I don't think it's out of school to say that systems like the ones at Amazon and Microsoft and Apple are a lot better than the sort of systems that public health has to track their information. And so if we get that kind of talent, if we can leverage the kind of talent in this next generation of emerging leaders across all kinds of different disciplines, I think we could really have a transformative future for public health and for disease surveillance and for making everyone healthier. And I think we have this moment of opportunity to do this right now. And so for me, the great thing is seeing that people not only have been affected, but how interested and eager they are to help. And so I think it's our job at the university and in other schools to harness that and really give people windows into how their unique skills, interests, and aptitude can be used and can contribute to fighting off the next one. So there isn't a COVID-25 or an influenza pandemic of 2028.
Tom, same question to you.
Well, I think building on Dave's answer, when I reflect on the pandemic, it's obviously, profoundly affected almost everyone in the world. And there's been huge amounts of just anguish and loss, and it's been really tragic. But I think it's also important to recognize that the burden and the tragedy has not really been very evenly distributed. And I think that that's another opportunity that we're seeing. That there are so many young people that we've interacted with, as Dave said, our own medical and PhD students and our undergraduates who may not want to pursue a career in bench science like we do, pipetting clear liquids into clear liquids, but they want to contribute in some way to improving health and improving the preparedness for future pandemics and improving health equity, both internationally and here in our own communities. And so I think that what's been really inspiring through the pandemic is to see how many scientists and medical professionals and public health professionals just sort of, rolled up their sleeves and decided to work together. Worrying later about who should get the most credit for what, but just trying to help on whatever scale they could, using whatever skills they had. And I hope that we can keep this spirit alive and, use the sort of galvanized attitudes that we've had to, try to help our fellow citizens and protect our local and global health. To build these bridges that weren't there before, to go out into communities that have been underserved and make sure that they have access to basic public health needs in addition to fancy genome sequencing for pathogens. I think there's a tremendous opportunity here to recognize these inequities and help health outcomes, and just genomic sequencing is just a part of this.
Well, I want to thank you both so much for joining us. Tom Friedrich and Dave O'Connor, virology professors and researchers at UW-Madison. Thank you both very much.
Thank you.
Thank you.
For more from Here and Now in PBS Wisconsin, you can visit pbswisconsin.org/news. And thank you so much for joining us on Noon Wednesday.